Hello, everyone, and thanks for joining us for this Part B Clinical Psychologist Common Rejections and Denials webinar. This is designed for those who submit claims on the CMS 1500 claim form or the 837P professional electronic claim. My name is Mary Muko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your speaker today, and assisting me is my friend and colleague, Bailey Lawson. We begin this webinar as we do with all of our other educational opportunities with a disclaimer. We include this disclaimer in our education to remind our learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage, and these laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And just as a reminder, CMS prohibits recording of this presentation for profit-making purposes. Now, this slide shows a snipping from the advertisement that we used for this event. It looks a little bit different than the agenda slide included in the presentation materials, but I'm showing this as a reminder of what we advertised would be included in today's presentation. During this webinar, and just as you see on the screen, I'm going to provide details on common rejections and denials, how to fix and avoid both, and I'm going to provide you with some resources. And remember that today's information is specific only to Part B clinical psychologist services. I did send an email yesterday to all registrants to remind you that these are the topics I'm covering today. I will respond only to those questions that are related to these topics, and in the interest of time, in that email I provided for you some other great resources that you can find to answer some of those unrelated questions that I did receive when you registered. Now, to fully understand rejections and denials, it's important to recognize the path that a claim takes, or what we like to call the life of a claim. This is a really simplified graphic on how a claim gets into our claims processing system. Of course, the provider would provide the service, he or she would submit the claim, and then in that very initial action, our system would either reject the claim or allow it into our system and generate a 277 or 999 report. And this slide really expands on what that graphic on the previous slide is meant to depict. Most providers submit claims electronically. Very few qualify for a waiver under a law that prohibits payment of services or supplies if a provider did not bill the claim to Medicare electronically. Now, to confirm claim receipt into the Medicare claims processing system, providers can use or should use the 999 report. You would use the 277 report for more specific information then. Our electronic data interchange, or EDI staff, provides helpful information on the Medicare 277 and 277, 276 and 277 companion guide, and this will help clarify and further define the data content requirements for an electronic claim. Now, based on these reports, you will know if the batch is rejected and if you need to correct or resubmit that batch to Medicare. Now, if you are a provider who employs a billing service, it may be the billing service that is accessing these companion guides for you, or these reports, I should say. Here's a simplified graphic then that shows what happens to a claim that Medicare deems as unprocessable. Means the same thing as rejection. CMS calls these unprocessable claims. So, of course, the provider would render the service, submit the claim, And then there is a reason that the remittance advice generates to say that this is rejected, this is unprocessable. And I'll talk about this more in detail. Typically, it's because there's an incorrect format, something's invalid on the claim, maybe something is incomplete, or the simple fact that something is illogical. I want to talk a little bit about rejections versus denials, and it's really important that everyone recognize that there is a huge difference between these. I think that people sometimes use these words interchangeably when they talk about a claim, but they are really very different. And sometimes I even catch myself doing just that. I'll call a denial a rejection or a rejection a denial, and then I have to step back and correct myself and recognize that these are really different services. The left side of this slide that you're looking at now shows information on rejected claims versus the right side listing that shows information for denials. A rejection is unprocessable. It's never processed. It's rejected. It's really returned on what we call the front end. And it means that something is missing or incorrect or invalid or illogical. And for these claims, because they were never processed, there are no appeal rights. You need to fix it and resubmit it. Now I've listed here MA130 and CO16. These are codes that you're going to see on the remittance advice when a claim is rejected or not, or unprocessable, I should say. And for these claims, the patient is not liable. You cannot bill the patient for a rejected claim. You need to fix it and resubmit it. Denied claims, on the other hand, are adjudicated. These are denied services, perhaps a claim line item, or maybe the entire claim is being denied. And this means that the information on that claim fails to meet payment criteria. And I've listed some examples here. Fails to meet statutory requirements. Perhaps that service being billed is never covered by Medicare. There could be denials due to medical necessity or frequency edits. In this case, they are denials, and sometimes the claim is denied because it fails to meet eligibility for either the patient or the provider. Now, for these claims, most have appeal rights available, and in that case, you will see the MA01 on the remittance advice. The MA01 actually provides appeal rights for a denied service or claim. And for denied services, patient liability is determined. It's not always a given that the patient is liable for that denied service. For example, those services that are denied because they are not medically necessary. If the provider failed to present an advance beneficiary notice of non-coverage to the patient in advance, then the patient cannot be held liable. The remittance advice is sometimes referred to as an RA. Sometimes people even refer to it as the remittance notice. And this notice that is sent to the provider includes codes that explain the rejection or denial. Here then is a graphic that shows the path for a processed claim. Similarly, the provider is going to render the service, submit the claim to Medicare, and after the claim is adjudicated, there will be a determination if the line item service or the claim is paid or denied, and then of course that remittance advice or RA is generated. I want to talk about the importance of the remittance advice or the RA. Sometimes we refer to this as the remittance notice, mentioned that previously. Most providers receive an electronic remittance advice or ERA as opposed to a standard paper remittance or SPR. Now, depending on how the claim is processed, it may include information about any adjustments made to the claim or those denials. It could also include information about something that's missing. Sometimes it even provides notice about refunds and offsets. The ERA provides payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank, or the explanation of benefits or remittance advice. The CMS Remittance Advice Overview booklet that some of you might have put away in a drawer somewhere is no longer available, and instead, CMS makes information about the electronic remittance advice on their website. So I'll have Bailey place a link to the Healthcare Payment and Remittance Advice webpage in the chat. So the remittance advice then includes information that really tells you or explains how that claim was processed or that the claim was rejected. As I mentioned, there are codes on the RA that provides information about the claim. There are claim adjustment reason codes, and these explain why a claim paid differently than it was billed. A remittance advice remark code, these are RARCs, R-A-R-C is the acronym. These provide more details about an adjustment described by a claim adjustment reason code, or what we call a CARC. C-A-R-C is the acronym there. Another type of code that appears on the RA is a group code, and these convey the financial responsibility for the unpaid portion of the claim balance. If you find a CO on the remittance advice, it stands for contractual obligation. It means the provider is liable. If there is a PR, it means the patient is financially responsible. You can find code lists on the Washington Publishing Company's website. This is the company that maintains those WARCs and CARCs and group codes for CMS. And we understand that some of the codes may be cryptic or even a bit out of date, and I'll explain that a little bit more later to you when I say out of date. For example, some of the codes may use an acronym that's no longer used by Medicare, and I'll point those out later. One example that I can think of is HICN, H-I-C-N, which is Health Insurance Claim Number. We all know that some time ago CMS did away with HICNs. We now have the MBI, or the Medicare Beneficiary Identifier. Just as a note to all of you, we, WPS, are unable to change those code descriptors. The only entity that can do that would be the Washington Publishing Company on behalf or under the direction of CMS. After reviewing the RA, you need to choose your action. For an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim. If the claim or claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service. You might also be able to use the clerical error reopening, or CER, C-E-R process, to fix clerical errors, and CMS defines clerical errors, and these include minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk more about the CER process later in this webinar. Another action to consider is an appeal. The remittance advice, as I mentioned, is going to provide appeal rights, that MA 130. It's the code that appears on the claim that provides those appeal rights, and I'm going to talk a little bit more about that later also. Registered users can use our transactional portal. That's the secure side of our website, our portal, to render a clerical error reopening or request an appeal. These are self-service tools that really do offer the most efficiencies. Our portal user manual will provide, or does provide for you, illustrations and step-by-step instructions on how to use these portal features. And for those of you that are not aware, we have some big news about the transactional portal. It is currently being updated. We're in the works. We listened to providers' comments, suggestions, and looked at the input we receive in those surveys we send. And we're currently working on a revision to that portal, and it should be released probably around the middle of April. That's the date we're being given right now. So look for new education on the portal. Everything that's out there is going to remain out there. It might just look a little different and be easier for you to use. So that portal user manual that I mentioned with those illustration and step-by-step instructions will obviously be updated also to reflect those changes to the transactional portal. We're excited. The changes being made are based on our provider feedback. We want you to know that we do listen and take those suggestions and that input. Take it to heart. we we want our providers to be satisfied with the service that they receive from WPS, and that includes updates to things like the portal. Next, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. I talked earlier about the clerical error reopening or that SIR process, and I told you I would share more details. This is the process that corrects human or mechanical errors, and clerical errors or minor errors, as CMS calls them, are really limited to errors in form and content, and that omissions do not include failure to bill for certain items or services. And examples of these acceptable clerical error submissions that you can use this clerical error reopening process for are mathematical or computational mistakes, transposed procedures or procedure or diagnostic codes, inaccurate claim data entry, misapplication of a fee schedule, or computer errors. There are also some examples of situations that cannot be processed as a clerical error reopening, and these are included in the resource that I've listed right here for you on this slide. It's called How to Request a Clerical Error Reopening. This particular resource available on our website includes what can be or what are acceptable clerical error reopening situations and those that are not. So we do highly recommend you take a look at that and use the self-service portal or request a SIR if you wish by telephone or fax if the situations apply. And remember that our portal user manual includes those instructions for you should you wish to use the self-service option, which obviously is the fastest way to get these taken care of. Let's talk about appeals for just a bit. For claim denials, not rejections, you most often can request an appeal, and the purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by MACs. The beneficiary or his or her representative may request an appeal on any service that's processed for them. Providers and suppliers, however, may appeal services for which they accepted assignment. For unassigned claims, though, providers and suppliers can act as the beneficiary's representative, but the beneficiary needs to sign an authorization statement, such as the CMS 1696, that's called the Appointment of Representative. In addition, providers and suppliers can request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or if the provider or supplier billed in excess of the limiting charge, and then the provider or supplier must refund any fees that are collected from the beneficiary. The first level of appeal is the redetermination, and a redetermination is the only level of appeal that's rendered by the MAC. And when I say MAC, what I'm talking about is the Medicare Administrative Contractor. That is, for those of you in our J5, Jurisdiction 5, and Jurisdiction 8 states, Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. Those Part A and Part B Medicare services are processed by us, your MAC, the Medicare Administrative Contractor. There are time frames that apply to each level of an appeal when you're submitting the appeal. Additionally, there is a minimum amount in controversy, a dollar amount, that applies to appeals level 3 and level 5. You can combine like denials on more than one claim in order to reach that minimum amount in controversy, or the AIC level. I highly encourage you to check out a great resource that's available on our website. I'm going to show it to you just a minute. It's on the next slide. It's called How to Appeal a Claim Determination. And remember that we do recommend using those self-service options for more timely processing. And here then are those resources. And remember, when we advertised, I told you that I would share some great resources during this presentation. Here are a couple of more. The first one is that resource available on our website, and the second one is one of my personal favorites that I like to share when I'm talking to providers about the appeals process, and that is the CMS fee-for-service appeals process flowchart. This is a flowchart that's updated annually, and it shows for fee-for-service claims each level of appeal. It shows time frames. How long do you, the provider, have to submit your appeal request once you receive the remittance advice? How long do we, the Medicare contractors, have to make a determination when you request that level 1 appeal? And it goes on to all 5 levels of appeals. The second level of appeal is the reconsideration that's rendered by the quick. Again, it shows those time frames to submit that appeal request and how long the quick, the qualified independent contractor, has to make a decision and inform you of their decision. That flowchart also shows the minimum amounts in controversy, or those amounts in controversies for level 3 and level 5. So it's just a great resource, easy to understand. It's a flowchart showing you all of these great tiers, I should say, and very easy to keep track of the 5 different levels and the amounts in controversy and those time frames and so on. So I like to share that with you. All right, this brings us to the data dashboard, or I want to talk about the data dashboard, the data that I pulled, that I looked at in order to bring you the information during today's webinar. As I mentioned to you, it's specific to clinical psychologists. Clinical psychologists are Specialty 68 as designated by Medicare. Specialty 68 submitted claims for Jurisdiction 5, Iowa, Kansas, Missouri, and Nebraska, and Jurisdiction 8, which is Indiana and Michigan, collectively is what I pulled and looked at or requested in order to bring you this information. Now, this dashboard that was designed by our data informatics folks at WPS-GHA. It's a department that we call Insight. They designed this dashboard so that people like me and my colleagues in provider outreach and education could go out there and mine the data. Similar to what they do. It's a dashboard. We plug in the variables of what we want to look at, and within seconds, that information comes back. I'm going to be sharing that with you in just a moment. So again, for those of you that might be wondering about this Specialty 68 that I keep mentioning, it is a code that's assigned to WPS-GHA providers when they enroll. During enrollment, providers self-designate a specialty. While a provider can designate a secondary specialty, it is only the primary specialty, the one self-designated, that is used during initial claim processing. There are some situations where a provider will request an appeal and state their secondary specialty, and then Medicare will consider payment on a previously denied service. But for the most part, or actually always, when a claim is processed that initial time, the only that primary specialty that was self-designated is considered for payment. We use the specialty when processing claims from more than one provider. Are they of the same specialty? Are they of different specialty? It makes a difference to Medicare in that claims processing system in those edits and audits to know that indeed there are 2 clinical psychologists seeing the patient on the same day. Or is it a clinical psychologist and a clinical social worker seeing the patient on the same day? There's edits built into the claims processing system to look for those kind of things. And what the computer is looking at is that 2-digit provider specialty that's associated with the provider. So Specialty 68 is clinical psychologist. A couple weeks ago, or at the beginning of the month, I held a similar webinar and I talked about specific errors for psychiatrists. Psychiatrists are Specialty 26. Today I'm talking about Specialty 68 clinical psychologist. I polled for claim submission dates September 1 of 2023 through December 1 of 2023. That data was last refreshed on December 12th. So that means that any claims submitted for this date range after December 12th are not included in the data. Well, some of you might be saying, "Hey, today's December or February 27th. Why did you last look in December?" These are updated on, it's a rolling 3-month basis. And the Insight team goes in and refreshes that data. And when I pulled all of this information together to create this presentation in your handout, I had to do it well in advance so that we could get those handouts published out on the website and available for you for today's program. We can go in, of course, and look at refreshed data if we need to. In fact, people behind the scenes are doing that a lot. But for this information today that I'm presenting during this presentation, it was last refreshed on December 12th. So here then, when I plugged all these parameters into this dashboard and I hit that enter key, I would say within 3 seconds, folks, these findings came back. I think it's fascinating that you can go and change some of the um, some of the drop-down list items if you want the parameters for this and look at it. So for example, I could easily have switched from Specialty 68 to Specialty 26. I could easily switch from Indiana, Michigan, Iowa, Kansas, Missouri, and Nebraska to Nebraska only, or to Michigan only. That dashboard allows us to do that. But I looked at all states in our Jurisdiction 5 and Jurisdiction 8 states for Specialty 68, and here they are. Top rejections. Rejections, remember, are unprocessables. These claims are never processed. These claims are submitted to Medicare and they're rejected because something's missing, incomplete, illogical, incorrect. You need to fix it and resubmit it. So during that 3-month period, for Specialty 68, there was 804 rejections because that claim submitted to WPS-GHA, a MAC, should have been submitted to the patient's HMO or health maintenance organization. That, folks, means that that patient has enrolled in a Medicare Advantage plan. So the claim should not have been submitted to us. It's rejected. We can't process it. Claim lacks information needed for adjudication, 466. For this one, what you're going to want to do is look at that claim and determine if there's additional reason and remarks codes and claim adjustment reason codes that provides additional information. There's information lacking needed for adjudication. Maybe a certain item on the claim form wasn't completed. Third bullet is similar to number 1, relates to HMO. Patient has HMO. Submitting to WPS-GHA is incorrect. We can't process those claims. The next one, and here's what I mentioned to you earlier when I said sometimes those reasons that print out, those reason and remark codes or claim adjustment reason codes, are a bit cryptic or they're out of date. This one is just a little bit off in that it actually reads and says on the remit advice, denied. And we're talking about rejections here. And I told you earlier, rejections and denials are very different, but this particular code, for whatever reason, reads denied, rendering physician number invalid and missing, 337 claims. So that means the rendering physician number was either typed wrong or simply not included on the claim. You need to fix it and resubmit it. It says denied, but we're talking about rejections here. The next one, missing, incomplete, invalid ordering provider, or excuse me, primary provider, 99 rejections in that 3-month period. Here's one that shows the clinic number is missing or not entered. 89, rejections. The next one, the claim must be submitted to RRB. RRB is the acronym for Railroad Retirement Board. We rejected 82 claims. Now that rejection is very similar to the fourth bulleted example here that says this claim has been forwarded to Palmetto, the Railroad Retirement Board. Now some of these claims are forwarded to RRB, some of them just outright reject and the provider needs to submit them. So if it says that the claim must be submitted to the railroad board, you need to submit the claim to Palmetto. If it says we forwarded it, you would not need to forward it or submit it to Palmetto because we're doing it for you. Third bullet there is a very popular one, not just for Specialty 68 providers, but a lot of providers. I talk about this one often when I'm educating about rejections and denials. That is that field 11 of the HCFA 1500, and there is another outdated acronym, folks. It's not the HCFA 1500, it's now the CMS 1500, not updated. WPS has no control over that. Remember, only that Washington Publishing Company at the direction or on behalf of CMS can change those remarks codes or those reason and remark codes. It also says denials, but this one is indeed a rejection. Field 11 is that item on the claim that asks the provider, is there any other insurance that is primary to Medicare, I believe. So let's move on. Denied, and of course we're talking about rejections here. Invalid or missing modifier. If that's the case, what you'll want to do is go to the modifier fact sheets that WPS-GHA maintains on the website to see if there is a modifier that needs to be appended or reported on your claim, or if you used one that is wrong and making that information illogical on the claim and unprocessable. And finally, the 10th example that I'm providing, or the 12th one here, is that the patient's HICN or the insured's HICN, health insurance claim number, again, that is now the Medicare beneficiary identifier, and the name do not match. 27 rejections in that 3-month period. So all of this information I mentioned to you, it's just fascinating to go out to this database and just, click buttons and boom, in a matter of seconds, this information comes back. I thought it would be interesting to share with you not just the top rejections by reason, but also by HCPCS codes. And here they are. You can see on this slide some of these codes, top rejections for clinical psychologists, are psychotherapy codes. These are those codes that are governed by a local coverage determination that WPS has written. So I would look to the policy and I'll show you that in just a bit, the policy and the coding and billing guidelines for WPS that include coverage limitations for these codes. You will also see when you look at these HCPCS codes, 96116, 132, 136, 133, 137, all of those top rejections are for codes that represent psychological and neuropsychological testing. And similar to those codes for psychotherapy, there is a local coverage determination that provides for you coverage guidance and limitations for psychological and neuropsychological testing. The number of that particular local coverage determination is L346646. And let me pull that over and take a look at that just for a moment. I want to show you something. I mentioned to you that it would show you the policy for that includes coding guidance and billing guidance, what's covered and what's not covered for psychotherapy. And it's similar to looking at this testing policy. When you look at one of our local coverage determinations, and this is the psychological and neuropsychological testing policy, you are going to see that this indeed is the policy written by WPS. Here's the document number L34646. This shows national coverage policy that applies and that was considered when we wrote the policy. Here then is the coverage guidance that tells you what's covered and not covered. Okay, so this will help you avoid those rejections denials. And for not just those local coverage determinations written by WPS, but for those LCDs written by other contractors, there is almost always a link near the bottom of the policy, and I'm scrolling there now, to a related local coverage document, which is the billing and coding guidance. A while back, CMS made changes to the process for local coverage determinations, and they required that all of the MACs, not just WPS, GHA, remove any code from a local coverage determination. So we removed the codes from the actual policy, but you can find those codes now, some codes, they're not all there, in the billing and coding guidelines article. Sometimes we call this the billing coding article. Sometimes you'll hear someone say the companion article. Sometimes people call it the article. But whenever there is a local coverage determination, typically there is an associated billing and coding article. That link to it appears at the end of the policy. So this then includes codes, coding advice. So for example, this is the Group 1 codes governed by this policy. Here they are listed. You'll notice that some of these are on that top rejection by HCPCS code slide. And then it tells you if there are any ICD-10 codes associated. This says that there are no ICD-10 codes listed in this article because coverage of the service isn't based on diagnosis, that you need to report the appropriate ICD-10 code. Now, if you're looking at the policy for psychotherapy, you will see groups of codes that shows for this group of codes, you have to bill one of these ICD-10 codes or it's not covered by Medicare. So some of them have codes that are covered, some say any code but these are covered, and then some say that we don't list any ICD-10 codes because coverage isn't based on diagnosis. So just some things to know. Again, coding and billing article, I'm going to pull the one over for psychotherapy. And this is the billing and coding for psychiatry and psychology services, which includes the psychotherapy codes. Here is the article guidance. I'm going to talk about this diagnostic interview in a little while. That's why I had this one at the ready. Here are codes that are governed by this policy. These are Group 1 codes. And then when you move to later in the policy, you'll see Group 2 codes. And then you'll see these are the covered ICD-10 codes for the Group 1 codes. So this is how you know which diagnoses Medicare or WPS will allow for these particular CPT codes, and they're listed here. So again, a great way to avoid those rejections and denials. One of the most problematic codes, or two, are the 90791 and 90792. Providers want to know or want help with avoiding these denials. In our policy or in our billing and coding article, it states that we will allow this service only once at the onset of an illness or suspected illness. You can repeat it for the same patient if an extended break occurs, if the patient requires admission to inpatient status, and that would be for a psychiatric illness, or for a significant change into the mental status requiring further assessment. So this, folks, is that frequency edit that applies for this service and for which GHA either rejects or denies services fairly often. What you need to do is submit your documentation that shows that you meet these requirements in order for us to pay for this service more than once within 6 months. This is a hard-coded edit, so it doesn't matter if Dr. A bills it and Dr. B does it. If it's done within 6 months, that second one that's submitted and processed by Medicare is going to reject and deny. So another way to avoid this type of denial is to interview your patient. I know that your patient might not always remember the specific types of services they had, but ask those questions. Have you been seen by anyone else? Have what did they provide for you? You know, what services were provided? And this will hopefully help you ascertain whether or not a psychiatric diagnostic interview exam was indeed billed by someone else. You know, ask the patient, when was it? They don't always know, don't always remember. I understand that, but these are just some of the things you can do to avoid these types of rejections and denials. One of the questions I had recently regarding these services was, well, what about, you know, the patient was seeing Dr. A and then Dr. A left, so we brought Dr. B on, so Dr. B did the psychiatric diagnostic interview. Well, think about that for a minute. Is it medically necessary that Dr. B does that same exact service that Dr. A already did within the last 6 months? The answer is no. So without documentation to show that it indeed was medically necessary, which is the overarching criteria for Medicare payment, we can't pay that second service. So just some things to think about here. All right, let's get back to those others, other rejections and or other denials. There we go. I somehow got moved back there. We're going to talk about top denials now. I talked about rejections a little bit and some of the resources you can use to avoid them. Most of them, you know, pretty straightforward. Um, if we can eliminate those top rejections, because most of the claims are coming to WPS when they should really be going elsewhere, you know, to the Medicare Advantage plan or to, you know, the Railroad Retirement Board, that's a lot of claims that we're not needlessly rejecting. And that's a cost savings for both the Medicare program and for the provider. If you don't have to submit that claim to the wrong provider or to the wrong contractor first, think of the money that will save. Okay. Top denials, look at that. The top two denials for clinical psychologists is that it's a duplicate claim. We already processed the claim. Uh, so look at that, 985 and 617 claims within 3 months. That's a lot of cost associated with denying claims because they're duplicates. If you have a billing service that just automatically submits claims every 30 days, tell them to stop. It is considered abusive to put this into a cycle and submit every 30 days. You need to wait for that remittance advice to see what Medicare determined. Did they process your claim? Did they reject it? Don't just automatically rebuild the claim or resubmit the claim. Medicare will not pay for this service for this condition, 430 denials. That means, sorry about that, folks. I have to go back to that slide. That means that the diagnosis wasn't covered for that particular service. So look to the policy for that information. Or the article, the billing and coding article. Claim must be sent to EGHP or LGHP. That is employer group health plan or large group health plan. So that is a Medicare secondary payer denial. So what you want to do there is look to the resources available that speak to how to correctly bill when another provider is responsible and Medicare is secondary, not provider, when another insurer is responsible for the claim. Physician or supplier not eligible to receive payments. That may be a situation where you need to contact provider enrollment. Why is that provider or supplier not eligible? Did you bill before their eligible date? That type of information. So the contact there to fix that would be provider enrollment. Medicare does not pay for this many services in this time period. Think back to the 90791 situation. Once every 6 months is what the policy says. If you're billing more than that, there is an edit in the system. It's going to deny. Now, you may have a medical necessary reason for rendering that second service or third or fourth. I don't know how many services in this case, but I'm kind of thinking this is the 90791. you can submit documentation and appeal if you believe that you should be paid for the second one. Time limit for filing your claim is expired. There are no appeal rights. If you submit your claim more than 1 year after the date of service, you have exceeded the time limit for filing your claim. There are no appeal rights. You can't appeal the service. There is a process that you can contact our claims supervisor and ask for the time frame to be waived or the time limit to be waived, but that doesn't happen very often. There's very strict guidance from CMS about when we can approve those and not. Duplicate, there's another duplicate. So 3 of the top 10-ish reasons for denial were duplicates. Next one, hospice service provided by a non-attending physician. Make sure you're checking eligibility, see if the patient's a hospice patient. And finally, info doesn't support the need for this service. That one you'd want to dive a little bit deeper. I'll tell you how to do that in just a little bit. Here are the top denials by HCPCS code. Again, the same types of services are hitting here. You're going to want to check the billing and coding guidelines for most of these denials, or the policy itself, or many of the other, some of the other resources that I provided. I do want to let you know that we can further break down the data. When we're looking at it, we can actually sort by specific state. Even then, if we're looking at Iowa, for example, we can then drill down by county. We could do state by HCPCS code, county by HCPCS code, or look at trending. And I want to show you an example of trending. Trending for both unprocessable and denials is possible. Again, click the button, the information's back in seconds, and this is all of the information that we can look at or plug in and view. Here's an example. The code is 434. That's kind of an internal code that's assigned to either the rejection or the denial code. There's a code description that will print when we, or show when we do this query in this dashboard. I use this one. This physician is not eligible to receive payment. It'll show us the current count for 3 months, 248. What about the prior 3 months? 167. The difference in those claims is 81. The claim percentage change is 49%. So in seconds, I can hit a button and I can see the difference in the claims, either an increase or decrease for this particular denial. Well, why is that important? Because this really kind of drives our education. What is it we need to educate providers on? What are we seeing these trends? How are we seeing these trends move? Are we going in the right direction? Are there less denials? Are there more denials? And so on and so forth. This is exactly what CMS wants us to focus on. All right, now on to some tools. I talked to you earlier about claim forms, and maybe something was missing from a claim form. Well, this particular slide includes for you the Internet-only manual, publication 100-04, which is the claims processing manual. In chapter 26, there is the completing and processing form CMS 1500 data set instructions. This, folks, goes by item 1, this is what you need on the claim. Item number 2, this is what you need on the claim and in this format. Item number 3, remember one of the top rejections, I believe it was that item number 11 wasn't filled out. This will help you understand what it is you do and do not need to include on your claim. And sometimes, remember, it's required information, and sometimes it's simply situational. It's only when this happens that you need to include this information on the claim. And because this is, these instructions are the paper form, item 1, item 2, item 3, I've included for you on this page a link to a really fantastic, I'm trying to find it here, a really fantastic resource. And I'm going to pull it over here. This is what we call the crosswalk. You can see the long name for it there on the slide. I'm pulling it up here on my other monitor, and I'm going to pull it over here in just a second. This is what it looks like. I mentioned to you, I'm going to try to make it a little bigger here, that in the IOM, in the Internet-only manual, we tell you, item 1, this is what you put on the claim. Item 2, this is what you put on the claim. This is the crosswalk to the electronic claim form. So for example, that item number 11 that I talked about is right here. This is the information that you have to place in it. Um, I want you to pay special attention to the status column, the S or the R. This tells you right here whether that information on the electronic claim is required or situational. And then, of course, it tells you where to put that information, which data element. Where do you need to put that on the electronic claim? So it goes from the paper item to where to put it on the electronic form, whether it's required or situational. And then it provides a little explanation of what it is you're reporting. So this is a great tool to help make certain that you are including all of the information you need on that claim form. All right, let's move on here. Here's a great website resource for rejections. I mentioned this earlier in the presentation. I just wanted to put all these resources in one, easy place for you to come back to after we're not all together today and you don't have a chance to ask questions. Here are the common claim denials. When you look at these on our website, and I'm going to pull that up, I talked about claim denials and reasons today. We have a really great resource on our website called Common Claim Denials that kind of categorizes the denials. This is bundling denials. This is the NCCI edit information that pertains to bundling, global surgery rules. Those are all kinds of bundling denials. Here's duplicate claim and service denials, and then examples of them. Entitlement denials. These are all those most common denials that I talked about today, and this tells you the reason code and remark code and how to fix them. So this is great information, as these are the most common denials and how to fix them. Payer contractor denials. If you have this reason code on the claim, this is what you need to do, and so on and so forth. Here's the situation that I did talk about for your claims. Specialty 68, patients enrolled in a hospice. What do you need to do? And here's the provider number denials. Okay, again, those reason and remark codes that I mentioned, if they appear on your remittance advice, this great resource tells you how to fix them, or what you need, or what you need to do to avoid them. All right, here's more really great resources for you. Provider enrollment guides and resources. These would be those provider number denials. Timely filing of claims. We talked about that being one of your top denials. This is where you can go. Well, I'm not going to go there right now. You can just click on this when you pull open your handout, and it will take you to the resource on our website that tells you about the process to ask our claims supervisor or claims manager to waive that denial of that timely filing denial. Here are more great resources. The database, CMS's database, tells you when certain codes are or are not valid for Medicare purposes. I've included for you as a resource some information about the IVR. You'll want to use the IVR for those eligibility and claim status checks. We do have an operating guide that includes instructions. Similarly, we have another self-service tool. Whoops. Went too far. For our portal, I talked about our transactional portal, the one that we're updating right now. This can also be used to check eligibility, claim status, claim details. When you are looking at a claim in our transactional portal, you will be able to push on a button that's labeled More Info. And that particular button will take you to even more details on why your claim denied. So great information. It's a great tool, provides a lot of information for you. Instruction is in that portal user manual. And remember, self-service tools is always the fastest way to take corrective action. That brings us just to a few minutes for questions. Bailey, I'm going to ask you, have we received any presentation related questions?
No, Mary, there aren't any questions.
All right. Our greatest compliment is when you recommend our WPS GHA education to others. Please consider doing this to help us reach the greater provider community and reach our goal to assure current and effective education for all of those in our MAC jurisdictions. On behalf of myself, Bailey, and all of Provider Outreach and Education at WPSGHA. I want to thank you for your participation, for taking time to be with us today. We do look forward to your survey comments, and we hope to have you join us for future events. You may now disconnect. Goodbye, everyone.